Good morning, good morning, good morning. How's everybody doing? Woo! Can I get a skego? Skego. Okay, perfect. So I have all of your attention now. Thank you so much for joining us on this auspicious day. It's so lovely seeing all your faces in person. I've had the pleasure of seeing many of you virtually, so I'm almost tempted to say, please please mute your microphones, but that won't be appropriate for the conversation. So I know I've been unceremonious. I haven't introduced myself. How rude of me. My name is Delaney Hines. My pronouns are he, him, and I serve as a chair for the Education Committee, as well as a member of the Board of Directors. And I've had the pleasure of co-chairing the planning for this summit alongside my colleague, Dr. Arabina Simpson, who couldn't be with us today, but she's here in spirit. Well, no, she's alive. She's just on vacation. She's also here in spirit, though. So I have the pleasure of, not only introducing our fearless leader who needs no introduction, but before getting to that, I want to make sure I kick things off appropriately with a land acknowledgement, a bit of housekeeping, and then just trying to kick off the day. So with that, the land in which we're currently situated on today is the traditional territory of the Ojibwe, Adirondack, Haudenosaunee, the Wendat peoples alongside the Mississaugas of Scugog Island First Nation and the Mississaugas of New Credit, all in the territory covered by Treaty 13. I personally locate myself on this land as a child to immigrant settlers. Both my parents came here from Jamaica, thank God, and they provided me a great opportunity to not only be here with you all today, but also to live, work, play freely on this land. Many of us and our ancestors have come here through a variety of different means, some of them being the transatlantic slave trade, the West Indian immigrant supply chain, or domestic scheme, sorry. But with all that being said, it's a privilege to also be here with you all this morning. I look forward to spending both today and tomorrow with you, and not only that, but learning alongside you. So, with that, I want to make sure I didn't lose sight of the housekeeping. So you've all been able to find the breakfast, which is first test passed. Secondly, I want to make sure you all know we are providing complimentary parking. So if you haven't had a chance to, before you leave today, do be sure to scan the QR code. You'll see it listed on this little placard I have here, but they're also situated in and around the floor here. Also, there is a paid meter somewhere in and around the parking lot too. So if you have already paid by way of the paid meter, this is no longer of any use to you. So please do ensure you use this QR code to register your vehicles. Can't say that enough. Also, as I mentioned, this is not a Zoom call. So if you could all place your cell phones on silent or do not disturb, that would be greatly appreciated. We want to make sure we have full attention directed to our speakers. And last but not least, if you do have your phones out, please be sure to help engage and bring excitement to the summit by virtue of sharing the summit on your social media, LinkedIn, Twitter, etc. Hashtag Skego Summit should be fine. I'll make sure that's posted somewhere for you throughout the week. Okay. We're about to get things started. I mean, I'm shivering right now with excitement, honestly. I'm so happy to see this come to bear. We put a lot of energy into bringing this to fruition, and now I have the pleasure of introducing our fearless leader, who I've already mentioned needs no introduction, so I'll do my best to do it justice. And I kid you not, this written bio is an underappreciation for all the things Ms. Lanre does, not only from her professional vocation of leading Skego, but just from the tireless, selfless nature that she brings to this initiative, this organization, is honestly unparalleled. And I'm just so happy to be able to, stand in her shadow, honestly, because she's a bright star, not only in just demeanor, but also in spirit. So I could go on, but she's also a global patient advocate for sickle cell disease and other inherited blood disorders. She has decades worth of experience in patient engagement and program development. She co-founded the Global Alliance of Sickle Cell Disease Organizations, which is GAS-CDO, as well as the Global Action Network for Sickle Cell and Other Inherited Blood Disorders. Don't worry, I'm not done. There's way more to go. She was also a past chair of the Network for Red Blood Disorders and a co-founder of the Ontario Hemoglobinopathy Patient Association. As the co-founder of the SCAGO and the Sickle Cell Disease Association of Canada, she has significantly raised the visibility of sickle cell disease in Canada. Her efforts include advocating for newborn screening across the country, getting World Sickle Cell Day enacted at the national and provincial levels, and influencing health policies to improve health outcomes of people with sickle cell disease. And she's been recognized for her leadership with several prestigious awards. She's also a fantastic mom, fantastic sister, great friend, great colleague. If you could please join me in a warm, roarous welcome for Ms. Lanre Tunji-Ajayi. That wasn't very roarous. Could I get a bit more energy? Like, yes, yes! B+ on the first attempt and A+ on the second attempt.
Thank you, Delani. Thank you so much, Delani. Thank you, everyone, and welcome. Honestly, it's so exciting to be here with all of you after COVID-19 pandemic. This is our first in-person since that time, and many of you who were there in 2018. Is it anybody here in 2018? Or so we have some folks here in this same room in 2018 when we had our last in-person summit, and it's just amazing to have you all here again. So we welcome you to the SCAGO Sickle Cell Summit 2024. I wanted to say this year's theme is Innovative Cures in Sickle Cell Disease. And many of us, just about 2-3 years ago, many of us were unaware that there were innovative cures in the pipeline, baking in the pipeline. But today, we do not only have cures that require a donor, like bone marrow transplantation. Now we have Casgevy. We have Lyfgenia. These cures did not require a donor. It just required taking your own gene, tweaking it, putting it back in your body, getting cured. Isn't that exciting? We are truly in exciting times, my friends, and we are so excited to present these therapies to you during this meeting. You might know that the Sickle Cell Awareness Group of Ontario was founded in the memory of Sunday Afolabi, who succumbed in 1998 to preventable complications of sickle cell disease. He used to say, I look for a day when no one would have to suffer from sickle cell disease pain or die from it. I think that day is fast approaching. We're so excited. I tell you, in the next 2 days, while you're here with us, you will hear from experts. You will learn about innovative cures. You will learn about modifying therapies which continue to be lifesaver for many people. Even though we're talking about curative cures, it might not be for everyone. Modifying therapies are still very important. Advocacy in sickle cell. How do you as clinicians be seasoned in what you do? How do you, as patients and caregivers, manage sickle cell disease more effectively to ensure we're not dying from preventable complications? How does the community become more involved and engage advocates on behalf of folks with sickle cell disease? We have so many topics, as you find in our agenda, that will be helpful to all of you today. At this time, I would like to thank our sponsors, Vertex Inc., supporting Black business initiatives, Novo Nordisk, Editas for sponsoring today's summit. Without their financial support, we will not be able to put this together, and we appreciate. I also want to appreciate, even from the start, our numerous volunteers, our speakers who are giving their time. Many travel from the US and all over. We want to thank all of you. We want to thank you, our attendees, for making this a priority, making sickle cell disease and learning more about sickle cell disease a priority by being here. Thank you. As Mr. Hines said, we want to make noise. We want to make sure that more people know about this summit, and if you're not here today, you're here tomorrow. Let's share. Take some of what you've learned and share it on social media. Let's educate the community on sickle cell disease. And on this note, I want to wish you an impactful summit with us, and I'll call back Mr. Hines to come and introduce our next speaker. Again, I thank you and welcome to Sickle Cell Summit 2024. Thank you.
Perfect. This is well timed. So, joining us for our first scheduled programming of the day, we have Dr. Rajat Kumar, who you'll be able to see his bio and his credentials in the summit guides you would have picked up during registration. He's a professor of medicine at the Department of Medical Oncology and Hematology. Dr. Kumar is currently at the University of Toronto in the allogenic bone marrow transplant program at the Princess Margaret Cancer Center. He was previously head of malignant hematology for 5 years. He hails from India, where he was a professor of hematology as well, and at the All India Institute of Medical Sciences in Delhi, where he had set up a bone marrow transplant program with focus on thalassemia. He then relocated to Canada in 2008 and was a hematologist and professor at the University of Manitoba in Winnipeg. He has a special interest in transplants and sickle cell disease and started transplants for adult patients with sickle cell disease in Toronto. He is also the local principal investigator for a gene therapy trial in sickle cell disease and thalassemia. He is currently co-chair of the Hemoglobinopathy Working Group of Cell Therapy Transplant Canada. So he'll be joining us to deliver his keynote for today, and I do encourage you all to network and meet with him following his presentation. So without further ado, Dr. Kumar.
Thank you. Thank you for that kind introduction, and I'm really honored to be here as a speaker in this wonderful conference to meet all of you. I hope I can work this. Yes. So the aim in the next 15 minutes is to give you an overview of hematopoietic stem cell transplant or bone marrow transplant in sickle cell disease, and also to talk about the promise and challenges of gene therapy, which you've just heard about. I do have one disclosure. I'm on the advisory board of Vertex Pharmaceuticals. This is a company which makes one of the gene therapies, which I'll be discussing. I'm also an adult transplant physician. So I think we all know that in sickle cell disease, there's increased morbidity, poor quality of life, and increased mortality because of the pathophysiology, which we know that the sickle cells under hypoxic conditions become misshapen, adhere to the vessel wall, undergo hemolysis, and all that leads to thromboinflammation of the blood vessels, causing damage to organs from the brain to the bone and so on. And this damage increases with age. So in a child, there's hardly any damage, but in an adult, you can imagine the organ systems are affected. Now, the reason why this is important when we talk of transplant and gene therapy, the results are always better in children, not so good in adults. The only way to cure it at present, proven, is by replacing the bone marrow. I call it bone marrow transplantation. And a few years ago, there were more than 1,000 cases presented with excellent results in children, more than 90% survival. But the results are not so good in adults because of the reasons I've mentioned. So the American Society of Hematology a few years ago issued guidelines, and this included experts, evidence, and patient reps. And what they stated was that a matched sibling donor is needed for a transplant. If you don't have a matched sibling donor, that should be considered in the context of a clinical trial. They also mentioned that in children, you can use myeloablative conditioning. Now, just to clarify the concept, myeloablation means wipe out the complete marrow. So it is very effective in ensuring donor engraftment, but it's also more toxic. Children tolerate it very well. But in adults, they mentioned non-myeloablative conditioning is preferred because adults don't tolerate myeloablation that well. And that makes sense, right? Further, if you want to know why matched sibling donors are recommended, so this is the study with more than 900 patients, and the top curve in blue shows the best survival is in those who have a matched sibling donor. Whereas if you have an unrelated donor or less related matched donor, the results are inferior. So that's why we want a matched sibling donor. And in the next few minutes, I'd like to discuss non-myeloablative conditioning and transplant, which is truly innovative. This contains absolutely no chemotherapy. What the patient gets is an antibody called alemtuzumab for 5 days, a single dose of radiation, and then infusion of the donor stem cells, a pretty high dose. And that's it. And they, of course, need a drug, sirolimus, an immunomodulatory drug, for more than a year. So it's very well tolerated. And I think it's best if I show some results. So this is a study from 3 different centers, 2 in the US, 1 in Saudi, published a few years ago. So they had more than 100 patients, and the outcomes are really remarkable. But please note, majority were adults, a significant number of 40 years and more. Now, one of the requirements is you need to have a major ABO blood group compatibility or only minor mismatch. And you also need a high cell dose compared to the usual transplants. Now, the results showed that 87% of patients had stable donor engraftment at 1 year. In other words, they were cured. Unfortunately, there was graft failure or rejection in 13%. However, they still survived, they just reverted back to the sickle cell state. So the overall survival at 1 year was 98%. So it's a very safe option, even in adults. One of the complications of transplant is graft versus host disease, but it was virtually nil or negligible. And more interesting, 14 patients had children. So fertility can be preserved, although not guaranteed in every case. Now, every patient of sickle cell anemia does not require a transplant, and there are certain indications by consensus, which I've shown here. I won't go through the list, but they basically have to have severe disease which is not controlled with supportive measures. For example, a stroke, recurrent vaso-occlusive crisis, chest syndromes, despite best supportive care. So only those patients need a transplant. So a bit of sharing of Princess Margaret, our experience. We started transplants using exactly the same protocol with a matched sibling donor about 3 years ago. Till date, we have done 8 such transplants and 3 are underway as we speak. The oldest patient was 48 years of age. All of them have survived, 100% survival. Hardly any graft versus host disease. And you'll notice that the hospitalization period was not prolonged. In the majority, the median platelet engraftment was within 12 days, and some patients did not need a single platelet unit. So kind of safe transplantation. Unfortunately, only 20% or less patients have a matched sibling donor. Now, in our other transplants, we often use matched unrelated donors, but the problem in sickle cell is graft failure or graft versus host disease is unacceptable in this condition. So that's why mud donors are not recommended. But almost every patient has a haploidentical donor. And just look at that cartoon. If you have a patient, they get half the HLA from each parent. So by definition, each biological parent is haploidentical. And if someone has 4 siblings, only one will be HLA identical, but 2 will be haploidentical. So it's very attractive to do haplotransplants, but some years ago, the results were not so good. Now that is changing rapidly, and I'd like to share this recent experience based on a phase 2 trial published just a few months ago. Now the conditioning protocol is shown here, and I know it looks very complex, but believe me, it is actually quite simple to administer. We use it routinely in our aplastic anemia haplotransplants. The only difference is there's one drug called thiotepa, which is also given in addition. But the results are so impressive. So this was a phase 2 trial across 3 continents with 8 sites, and they reported 70 patient outcomes. And interestingly, the bad news is some patients did have graft failure. That's about 11%. But if you look at event-free survival, that means no death, no graft failure. Overall, it was 82%. But in adults, event-free survival was 95% shown at the top red curve. So the graft failure actually occurred only in children. The cause is not clear. Possibly children have a more robust immune system and they needed more intense conditioning. But if you look at the overall survival, it is around 94% both in children and adults. Because these children who rejected their graft again recovered, they just went back to the sickle cell state. These patients did have graft versus host disease about 10%, but by the end of a year, only 2 patients needed immune suppression. So generally it's a fairly safe procedure except for this complication, and that really opens up haplotransplants for a large number of patients in the real world. So let me now switch gears to gene therapy. You've heard a bit about it earlier. The most attractive part of gene therapy is you don't need a donor. Patients' own cells can be modified. Okay? However, it is not that simple. There are some problems there. So let me explain. So if you have a patient, the first requirement is that we must collect cells from the patient. And that is done by apheresis, and it can be a challenge. I'll come to that later. The next step, if we get enough cells, these have to be modified. And there are many different kinds of gene therapies. So this is an oversimplification. The gene can either be edited, or you can introduce a different hemoglobin-producing gene. This may require a vector like a virus, or it can be through physical means like electric currents, electroporation. And in the interest of time, I won't refer to all of them, but I'm glad that Dr. Donna Wall, who's an expert, will be delivering a talk in a later session, and she will talk about the different kind of gene therapies and trials. Irrespective, once the gene has been edited or modified, it has to be infused back into the patient. Now this sounds very simple, just give it like a blood transfusion, but if we just infuse the cells, they will not grow because the underlying sickle cell will have the advantage of surviving. So they all need myeloablation, and that is one of the major problems here. And then they need to grow back. So let me now talk about the gene therapy which is now under consideration by Health Canada. This is a CRISPR-based therapy manufactured by Vertex. It was approved in the UK in November last year, and then by the US FDA in December. And currently, Health Canada is giving it a priority review, and we hope in the next few months it will be approved. It's got a name which is complicated, hexagamglogene autotemcel, but the easy term is exa-cel. And before I proceed further, it's good to know how this works. So every fetus, has fetal hemoglobin or hemoglobin F before birth, and this binds very strongly to oxygen. After birth, fetal hemoglobin production is switched off through the action of a transcription factor, BCL11A, shown there on top. So the hemoglobin F gradually, goes out of circulation. By the end of 1 month, it's less than 1%. Now, in a child with sickle cell disease, there is no sickling for the first few months because fetal hemoglobin provides it with enough oxygen. And when the level goes down, then they get the sickling complication. Some adults have fetal hemoglobin throughout their adult life. It's called hereditary persistence of fetal hemoglobin. And they do not get the manifestations of sickle cell disease. So the theory is, if we increase the fetal hemoglobin to 30 or 40%, we can cure functionally sickle cell disease. And this is done by this very innovative CRISPR technology. So what it does, it targets BCL11A very, very precisely. Only the BCL11A in the red cell precursors, not anywhere else in the body. And it cuts 2 DNA strands. So BCL11A, which is suppressing hemoglobin F production, suddenly is not functional. So we reactivate fetal hemoglobin production. The theory being this will now cure the patient. The steps in production are the same. First collect the cells, then manufacture, then give myeloablation and infusion. But the results of the trial with this therapy are very impressive. They were presented in New England Journal of Medicine a few months ago. So the study showed that 97% of patients who were having vaso-occlusive crisis before gene therapy did not have any such recurrence later. And just focus on the top right side screen, that's a waterfall plot. Each patient's data is shown as a horizontal line. So on the left side is the patient before gene therapy in the slight pinkish hue, and each blue diamond represents a vaso-occlusive crisis. Then they get the gene therapy and washout period shown in the middle in blue, and the green part depicts the follow-up. And as you can see, almost all patients were relieved of vaso-occlusive crisis. Some of them did have it, and that was mainly related to some viral infection. In the lower part of the plot, it shows the inpatient hospitalization due to vaso-occlusive crisis, again, a major benefit. They also looked at the mean hemoglobin, which is shown in the graph on the lower left, and the hemoglobin of the patients increased to between 11 and 12 grams per deciliter without any blood transfusions. In Canadian terms, it's like 110 to 120. And the fetal hemoglobin increased and remained between 30 and 40%. And this was also in the individual red cells. So this therapy works and is a functional cure. But there are problems which I mentioned. Firstly, how do you collect enough stem cells in these patients? So each patient needs transfusion support, red cell exchange for at least 2 months before the first collection. The collection is done by giving a drug plerixafor, and it is done over 2 or 3 days. But the efficiency is not very good. So patients often need not 1 cycle, but 2 or 3 cycles of collection with a gap of about 2 to 4 weeks in between. So it could be many months before we collect enough cells, and in some it may not even be possible. Now, having collected the cells and manufactured the modified gene, they need myeloablation. And as I mentioned earlier, that can be toxic. So they need special busulfan monitoring. And then recovery of the cells takes time, even though it's their own cells. And as you can see, the time for platelet recovery could be more than a month compared to transplant where it's much less. And they need hospitalization for, on an average, a month, but could be much longer. So it's very good treatment, but it's not entirely non-toxic. So to conclude, both transplantation and gene therapy are evolving and constantly improving. And in the next few years, you'll find many more advances. I think it's fair to say that we can now think of curing virtually all patients with sickle cell disease if they are otherwise fit. But to make sure that this is comprehensive, available to all patients in an equitable manner, there has to be excellent coordination between the referring physician, the transplant team, and you have to increase the resources of the blood bank to give the required blood, genotype blood, to collect the cells, do the transplant, to ensure fertility, preservation, to have good collection centers, increase hospital beds, have the support services like transport, stay, finance, and the most important part, to educate patients and their families about these possibilities, the benefits as well as the risks, so they can make an informed decision. Thank you for your attention. I don't know if there are any questions or... Yes, please.
Collection, would they be able to use their own stem cells for the treatment of sickle cell if they don't have any other siblings?
So that's a very good question, and I would just like to say much of that stem cell banking is not actually very useful. So let's say someone has sickle cell disease, you collect their stem cells, they will produce the same sickle cells. So you don't use their own cells for them. It will
but
not
at
work.
birth, if they're born, so it's like stem cells from their at birth, not like when they're an adult.
Yeah,
it
so
doesn't
at
matter.
birth, the stem cells have the same gene which they have. So let me give an anecdote. I was asked to collect cord blood from a newborn because the elder sibling had thalassemia. So I collected it, but the newborn also had thalassemia. So these cord blood were useless. So the more important thing is you need someone else who does not have sickle cell to use them. And generally, someone in the family, at least parents, are half match, as I just showed. Okay.
Hello, good morning. Thank you so much. My name is Angela Carter. I'm representing Roots Community Services. Just a question then, when we cure the sickle cell disease, does this mean that a patient who is cured can have children and then don't have to worry about who they marry and who they don't marry, so they can have children that wouldn't pass on this disease?
Okay, so they may have children depending on the protocol we use. For example, with non-myeloablative, their fertility may not be impaired, but we generally say you should do sperm or ova banking. But the genes in these fertility cells are not different. So we have cured their bone marrow because their bone marrow is now the donor's bone marrow. But their eggs or their sperms are the same as their own. So they need the same precautions which any patient with sickle cell will need in any case. So you don't change their fertility cells. I hope that answers your question.
We have time for maybe one more question. And please do recall that Dr. Donna Wall will be delivering a bit more of an in-depth conversation around this later on in the summit. So,
Dr. Stewart here. Thanks for the presentation. As you talked about health equity, this sounds amazing. Huge advancements there. My concern as a family doctor is always cost. And I know we're early in terms of the study. Is there things in place to start addressing that or thinking about that? Because as you know, with the population that we're serving, they're not going to be able to afford a lot of what we're looking at. So what are some of the considerations being had right now?
That's an excellent question. And I'm just part of a working group with the Canadian Transplant Center. We had our first meeting last month just to address the questions which you have addressed, which you have alluded to. So to ensure every patient gets the benefit of the best treatment, we need to spread the word and partner with people, not just transplant or specialists, but the family doctors and the kind of organization you have here. Because unless we create that awareness and the referral for the appropriate patient, it will be available to select patients. But I don't have an answer. But we are trying to create that network so that we can spread the word, information, and ensure everyone gets the same benefit, irrespective of where they live, which province, which place, which city. Okay, thank you so much. And I may just add, Dr. Wall will address this in greater detail. For more technical questions, please ask her. Thank you.
All right, everyone. Another round of applause for our keynote speaker. Thank you so much. All right. And we're going to be starting our next session now, the role of advocacy and crutch falling in health systems change. So I would like to welcome our first speaker in that session to come up, and that's Ms. Lanre Tunji-Ajayi. I think most of you were here for Ms. Lanre's introduction earlier this morning, but for those of you who weren't able to hear about all the incredible work that Lanre has been doing, I'm going to introduce you again. So as most of you know, Lanre is a global patient advocate in sickle cell disease and other inherited blood disorders with decades of experience in patient engagement and program development. She co-founded the Global Alliance of Sickle Cell Disease Organizations and the Global Action Network for Sickle Cell and Other Inherited Blood Disorders, GANSID. She was also a past chair of the Network for Red Blood Disorders and co-founder of the Ontario Hemoglobinopathy Patient Association. As the co-founder of SCAGO and the Sickle Cell Disease Association of Canada, she has significantly raised the visibility of sickle cell disease in Canada. Her efforts include advocating for newborn screening across the country, getting World Sickle Cell Day enacted at the national and provincial levels, and influencing health policies to improve health outcomes of people with sickle cell disease. She's been recognized for her leadership with several prestigious awards, and I am very excited to listen to her session this morning. Please welcome Ms. Lanre.
Thank you, Jennifer. Would you want to sit here? Would you want to sit? No. Thank you so much, even though I'm not sure I needed to be introduced. Thank you. I appreciate that. So first of all, let me say that many organizations, patient organizations that are established, are typically established by individuals who have passion, who maybe have a personal story. Because you don't just wake up and say, I want to create a sickle cell group or a cancer group. Typically, there's a story why you're motivated to do that. But many times you find that those individuals might have the passion, but they might be lacking resources. They might also be lacking the skill sets to effectively work, especially at the government level. So today I hope I can share some slides and to support us, especially I think both clinicians and also non-clinicians can be effective advocates. And there are some ingredients that we need to be mindful of. So first, what is advocacy? Advocacy is simply an activity either by an individual or a group that is actually meant to influence decisions. It could be within a political, economic, or social system, or within an institution. It could be within an hospital, and so on and so forth. And anyone can be an effective advocate. Anyone. So there are key ingredients we need to note when we talk about advocacy. Number one, you need to present your arguments with facts. So it's not sentiment, it's not just emotions. You need to present evidence to really back up, your arguments. You have to also be timely in your presentation. For some reason, I could not see my slides very well. You need to be very timely in your presentation, so presenting at the right time will be very impactful. So for instance, if you're working with the parliamentarians, you need to know when is the right time to really bring my argument forward, and all of those will help to ensure that you achieve success. You must package your presentation very well. Your messaging must be very clear and well presented. So first of all, what are you asking for? So effective advocacy means knowing what you want, be realistic in that expectation, and be focused. You will get sometimes a lot of no's before you get your yes. You do not get discouraged. You do not get frustrated. You focus on the goal, what you're trying to achieve. So your priority is number one. What are we asking for? Is it realistic that we're going to get this? In what context? Is it at a provincial level, a national level, a global level? Who is my audience? Who do I need to engage with? So recognizing your audience is a critical part in effective advocacy. You need to understand, so for instance, if you're working at the national level, you need to understand which parliamentarians do I need to be engaging, what is their role, what impact can they make to help me achieve what I am trying to achieve, and who is best positioned to help effect change. So while you don't want to be partisan, you also have to recognize things like the government in power will most likely help get your asking to reality than the opposition. So those things are very important to note, and you want to work with everybody, but you want to also understand who is best positioned to help effect change and champion this issue. So for instance, in the different parties, you want to also understand who is a great champion, who has some maybe political will, some empathy. So typically we would do our research, we would know who maybe have a family member with sickle cell or an inherited blood disorders that might be interested in our cause and wants to help us achieve what we're trying to achieve. If someone doesn't have a story, they might not really be interested. So you're going with somebody that has story around maybe multiple sclerosis, and they're interested in multiple sclerosis, not so much in sickle cell. So you really have to look at those champions that can really help you move your stuff forward, and who can speak and inform their colleagues on this subject matter that you are so passionate about. And like I said earlier, frustration when you are not getting your way, when you are getting a lot of no's, your emails are not being answered, you're calling their office and, oh, they're in a meeting, oh, they're busy, they'll call you back and you don't hear back. It's understandable, but long term is what you need to look at. Like if you keep persistent, persistency is a key ingredient in advocacy and one that it's so important to help you get your way. Long-term relationships also matters, right? You need to build that. You need to work with them over time. So first, you need to build an advocacy team. Who should make up your team is very important. So number one, when you're looking to work on an issue, people that are directly affected by the cause are very important. Their families and friends have to be engaged because it's about them. Healthcare practitioners, I cannot overemphasize this. Patient advocates are great, patient organizations are doing great work, but without, in a disease area, without the technocrats, without the clinicians, you can't do it alone. You gotta work hand in hand with the healthcare practitioners. They can supply the facts, they know, they're the clinicians, right? And then you can also seek third-party experts if you need that, and of course work with your colleagues and supervisors. You also have to schedule meetings, and that is very important. So you're trying to schedule meetings and you're not returning. Don't give up. Don't give up. You keep at it. So let's talk about effective advocacy interactions. So number one, you got to schedule meetings and make sure you are not late to those meetings. It's going to be very unfortunate that you schedule a meeting and the person you're trying to meet from the government side are there and you're late. That's not a good first impression. You agree? Meetings can be by phone, it could be virtual, it could be in person. Just make sure you schedule those meetings and you make it and you are well prepared for those meetings. Also, there's something we call situational interaction. So you see them in an event or somewhere. Oh, you go introduce yourself again. Oh, do you remember me? I just called your office and da. Just keep yourself in their face. Let them keep seeing you. Let them keep hearing from you. And also, as much as possible, engage them publicly. So number one, stay focused. Be polite and respectful. Even when you know they're trying to brush you off, just be polite. Provide practical and achievable recommendations for action when you do meet with them. Give precise examples of documented experiences. So for instance, scheduled last March, just this March, we had an action day at Queen's Park whereby, we've been working and telling the Ministry of Health that parents of children with sickle cell traits should be informed automatically. Currently, they have to request that information. Many are not requesting because many do not even know about sickle cell trait, right? So we had an action day whereby, we are saying this has to be automatic. And now work is being done towards this now, so this will be announced shortly. But what I'm trying to say here is that we gave examples where this has already been done, right? So in the Maritimes, when newborns are born and they have sickle cell disease or sickle cell trait, families are automatically informed. In Alberta, it's the same thing, right? And then that is followed with counseling to help parents understand sickle cell trait is not a disease. And why you are being informed and so on and so forth, they are being supported. So you give precise examples, it's being done. It's not like you're telling them to do something that is not being done before. Again, do your homework, understand their goals and limitations, what they can do, what they cannot do. And if they cannot help you, find who can help you. Always take notes. Always take notes. Don't think, oh, I got it all here. When I get to my office, take notes because you might forget very key points. And always take the initiative to continue the discussion and stay in touch. Remember, It's not just your course that's coming to them. Sickle cell is coming to them. Cancer is coming to them. Diabetes is coming to them. Everybody's coming to them. If you feel like, oh yeah, we had the meeting, they will get back to me. Oh, you get back to them. You say, remember we had the conversation, we had the meeting, I'm following up, what are the next steps, what do we need to do? I remember when we were gonna get June 19 enacted in Ontario, I went to my MP, she had no clue. I live in Barrie. She had no clue what sickle cell disease was, and she's like, oh, I have another bill that I'm championing, I'm sorry. And I said, no worries. So I started looking around, who else can support? Who else can support? Everybody has a bill that they're already sponsoring, and I know you can only be pregnant with one bill to be effective in really pushing that bill forward and debating that bill. So we kept looking, and then I went back to her after a year and I said, hey, Andrea, I know your bill has now passed. Let's talk again, right? Like, I'm not letting go. And she said, yeah, we can talk again. And she, along with Rudy Cocheto, now, we didn't even have just her. Rudy Cocheto from Mississauga also said, hey, Lanre, yes, I can also support. So they co-sponsored, and it was the fastest bill, I can tell you, that got passed through the process within 3 months and got enacted in 2021. It's about keeping at it, don't get discouraged, just working at it, right? And if they do anything positive, they mention you, maybe during question period or anything, just reward their action, let them know you recognize what they've done, share them on social media. They love attention. Just give a little bit to them. So, supporting materials. So, number one, you can have a document that clearly communicates your ask, be concise and practical, ensure that those materials are something they can easily check and make sure that you have facts in there, provide references and contacts so they know you're organized, they know you know what you're saying, and you're not making anything up. Golden rule, you are more knowledgeable than they are. I remember when we're trying to get June 19 enacted at the national level, we had a breakfast event with parliamentarians, and people were asking us, what is sickle cell disease? Does it affect Black people only? Like, they just don't know. But you know why? People might say things like awareness days are very simple, they are very easy. Why do we even worry about it? But you know what that does? It raises awareness with policymakers. If I go to them and I say, I need 10 billion to do sickle cell program, if they don't know so much about sickle cell, they're gonna say, well, yeah, cancer needs 10 billion, and diabetes need the same amount of money. Why should I give it to sickle cell? When you do a day, awareness day first, when you do something like that, you know what that does? Because when they debate on the bill, for instance, they have to learn about the disease in order to debate the bill. When they learn about the disease, what's happening? They are developing empathy for your disease. So you start with low-hanging, non-costing stuff, and then you can go back and you can ask for things that cost money. Now there is rare disease strategy that has sickle cell involved, that's getting $1.5 billion at the national level. Now we are able to work at provincial level with the ministry and get comprehensive centers, across the province, because you've done that due diligence, right? And like I said, negative attitudes, sometimes you might get negative attitude, you might be brush up, it might be because they do not understand. So it's your job to educate them and so on. Do not be loud, do not be frustrated, because that will not result in effectiveness and it will not result in success. So I've given some example about what SCAGR has done. You need to understand the legislative process. So with her sickle cell awareness day bill, you need to know when the legislature is in session, and when can a private member's bill be introduced, What are the steps required for it to pass? How do we maximize our chances of success? And make sure the delegates that you're using to meet with parliamentarians have good understanding of what you're talking about. Again, you need to build relationships with key political advisors, meet with them, right? And so, like I said, I gave the example of my own MP with Rudy Cacheto, what they were able to do for us, be nonpartisan, but recognize that, you know, government in power will be able to help you get your bill into lower than anybody else. At SCAGO, for instance, we work closely also with Thalassemia Foundation, Black Earth Alliance, community centers, all of those things. So build a connection, a collaboration to make this happen. And like I said, this bill was expedited and passed within 3 months on June 3rd, 2021. And so on that note, I think that is the last slide. Thank you again for listening to me. Thank you.
We're going to save questions until the end of this session, so I'm going to invite our next speaker to join us up on the stage, Paulysha DeGan. Paulysha DeGan is the Manager, Equity, Inclusion, Diversity, and Anti-Racism at Ontario Health. In her role, she leads province-wide equity initiatives that include the Black Health Plan, advancing inclusive 2S LGBTQIA+ care, reporting, and more. She has held a variety of other health equity and policy roles at prominent organizations over the years, including the Canadian Cancer Society, CAMH, Ontario Ministry of Health and Long-Term Care, and more. Paulysha completed her master's in public health and health promotion at the University of Toronto. All right, and I'll turn things over to you now. Yes.
Good morning, everyone. Hope everyone is doing well today. And thank you for the warm introduction. And so I'm just going to talk a little bit about how we are advancing Black health at the systems level, which was a really nice segue from talking about advocacy from my previous presenter. So on this slide here, I'm giving quite a lot of data, but I want to draw your attention to a couple of things. First, the title of the slide. The risk of mortality in Canada is higher for Black males and females compared to their white counterparts across various health conditions. You'll see on the left-hand side a variety of graphs demonstrating how those different impacts are. And so for folks who aren't aware, a hazard ratio of 1 or over means you're at greater. And so if I want to draw your attention to some of the main facts here on the slide, on the top right-hand side are some key points just to draw out that. For example, Black males and females are at 5 and 21 times greater risk of mortality from HIV, respectively. We also see that Black males and females are at 1.2 and 1.4 times greater risk of mortality from diabetes, respectively. And not pictured on the slide here, but another statistic where we're seeing disproportionate impacts are that Black women have a 48% higher mortality rate for endocrine disorders. That includes sickle cell disease. So really what I want to demonstrate across this slide with a variety of stats that are shown here is that we are seeing disproportionate impacts that are affecting Black folks across both genders. And this data really demonstrates the necessity of the Black Health Plan as a tool to respond and disrupt these disparities and build the foundations that are required to address some of these impacts. And so we saw with the COVID-19 pandemic how it exacerbated existing disparities, and really the Black Health Plan from Ontario Health is working to alleviate those. So what is the Black Health Plan for folks who aren't aware? The goal is for health system transformation for Black communities, and pictured on the right-hand side is the cover page of the Black Health Plan. And so the Black Health Plan was formed in 2020 between Ontario Health, Parkdale Queen West Community Health Centre, and the Wellesley Institute in response to some of the disproportionate impacts we were seeing being exacerbated by the COVID-19 pandemic. And so it really was a goal that provides a coherent plan outlining urgent and long-term priorities and community-informed actions to improve health access, experiences, and outcomes for Black populations across Ontario. And the contents of the plan include recommendations, next steps to advance health equity for Black communities, including a discussion of events for implementation and key players and how we all can work collectively to advance Black health outcomes. The has been informed and stewarded by community members, health leaders, and academics, and I really do encourage folks to delve a little bit deeper into the Black Health Plan and check it out on the Ontario Health website. Going a little bit more into details, what are the focus areas of the Black Health Plan? Again, another slide with a lot of different information, different buckets, but I want to draw your attention to the two boxes on the right-hand side with deliverables. I know the font may be a little bit tiny, but really the Black Health Plan has 4 major bucket areas where we're focused on: primary care, chronic disease management, and pediatric care, and mental health and addictions. And then on the right-hand side, the other bucket box is around what's enabling us to success. So how are we going to achieve improving outcomes across those 4 domains? I do want to draw your attention here that one of the priorities under chronic disease management is explicitly mentioned to be the sickle cell disease quality standard. So that is something that we are working to address the disproportionate impacts of. And so during the pandemic, Ontario Health did work very closely with SCOGO in terms of coordinating sickle cell disease clinic implementation. So happy to be here again and seeing how we can continue to work forward to address disproportionate impacts as well. And so on the right-hand side, you'll see identified some of our enablers. And so one of the enablers that we have established during 2020 was that working closely with partners, and that includes the Black Health Plan Working Group. And the Black Health Plan Working Group includes folks from a variety of sectors, all coming together towards a joint goal of advancing Black health outcomes. And so SCOGO is one of the examples of organizations that we work closely with in the Black Health Plan Working Group, but there are other domains in which we work closely with partners. And I just want to make it very clear that this kind of work cannot be done in isolation through us as a government body, in isolation through SCOGO alone. It just really is a great demonstration of how working together across sectors, across organizations, is how we really are working towards advancing Black health outcomes. Speaking a little bit in terms of a spotlight on sickle cell disease specifically in its relation to the Black Health Plan. And so Ontario Health launched a sickle cell disease quality standard in early of 2023. And quality standards really have a role of providing the blueprint to enable efficient health system operations and ensuring all patients receive the same level of high quality care. But we can't just develop a quality standard. What are we doing thinking about next steps and implementation as well? Sickle cell disease quality standard was our first quality standard to be co-chaired by someone who had lived experience, and the first instance where addressing anti-Black racism was named as one of the quality statements. But thinking about how we implement the quality standard, that has also included the launch of a sickle cell disease community of practice with participation across the province and across various folks in the health sector. The use of e-reports that provide both regional and hospital-level data, and some of that includes wait time, % of repeat visits to the emergency department. So we're really monitoring to see how we're making progress against this with the implementation of the quality standard. And we also have been providing investments to expand sickle cell disease care, which are listed on the slide here, including investments in supporting pediatric access to sickle cell disease care in community settings, psychosocial services to support sickle cell disease patients and families, and the expansion of sickle cell disease clinics themselves across the province to improve reach and access to pediatric and adult populations. Now, I don't want to just talk about us and our role in Ontario Health in the system in terms of how we enable success, but really want for folks to take away some key takeaways for enablers of success, how you can also advance this in your own respective roles. Some of the enablers that we have identified for us specifically in Ontario Health, and you may also leverage as a tool as well, is that we have Ontario Health's Equity, Inclusion, Diversity, Anti-Racism Framework, which is a guiding framework for advancing health outcomes across the entire continuum. The work is built upon evidence-based decision-making, enabling and including what we're hearing from communities, as well as the collection and use of data, so leveraging what we have and using that as a tool to advance health outcomes. We also are aiming to reduce disparities as the starting point for designing programs, and not something that is off the side of someone's desk, really thinking about how to work towards health outcomes as the target for populations who are in greater need. In practice, this looks like embedding the Black Health Plan into large provincial strategies like the Ontario Cancer Plan, Sickle Cell Disease Quality Standard, and the Ontario Renal Plan. So meaning that we're not having the Black Health Plan operate in isolation, we're embedding it throughout and thinking about various priority areas and how they too can intersect. Another enabler that we have is transparent reporting, and this is to ensure clear accountability, and it is important to maintain progress and success of the work, drive improvement, and really to demonstrate the populations we serve are actually seeing improved outcomes. And then lastly, this work requires sustainable policies and investments to maintain and further its reach and impact, target interventions where they are most needed. And so these strong commitments are really needed as an enabler to success. Now, if folks are looking for a roadmap, not to just where folks are, then you may find some of that roadmap through our Black Health Plan, through our Equity, Inclusion, Diversity, Anti-Racism framework. But if you also are interested in connecting further, you may contact us at this email here. Thanks again, everyone, for being here. And I really do want to emphasize again how much it's important to work in partnership. So thanks again.
Thank you so much. And that was very quick at the end.
Quick reminder, folks, please place your phones on silent or on do not disturb during the sessions. Thank you so much.
And again, we're going to save questions to the end. I know there are going to be a ton for our speakers so far. I'd like to welcome Mr. Paul Bailey to the stage. Paul is a strategist, urban planner, and executive director at the Black Health Alliance. He's spent the last decade designing interventions focused on improving outcomes for Black children, youth, and families as it relates to health and well-being, community violence, mental health, and addictions, and the social service sector. His work is currently focused on social planning, health equity, and addressing the causes of neighborhood distress and inequality. Mr. Paul Bailey.
Right. Good morning, everybody. Can you hear me? Yes. Great. Delaney said this morning, stop looking like you're nervous. I don't like mics, so if you can't hear me, just let me know. Just, speak up and I'll pick it up. Happy to be here this morning. Happy to be a long-standing partner of SCAGO. My name is Paul Bailey, and I serve as the Executive Director of the Black Health Alliance. We are an organization that's focused on centering the voices of Black Canadians about the challenges and barriers affecting our health and well-being. We work and provide a platform for community to establish a progressive and common voice around systemic issues that concern our health. And in many ways, we work in between community and government to try and drive and implement solutions that, again, improve our health. The approach we take, I think, comes from years of learning. It's interesting. Lanre was on the board. The organization's been around for about 25 years. And as different folks have come through the organization, they've left different vestiges of impact that I think we've now tried to craft into a stronger organization. So it's been a little bit of community engagement and bringing people together. It's been a little bit of research. It's been a little bit of advocacy and policy and learning the craft of systems change. And then realizing that we can't just, do some research, do some advocacy, put some things in a report and say, here's what we recommend. We actually have to identify what the specific change is that we want and drive it relentlessly. So that's what we do. We try and ensure that, after we listen closely to community, every solution that we co-create with folks is built on solid data. We try and ensure that we're building a shared vision and that we move quickly from idea to implementation. Ultimately, we're working to ensure that Black communities, Black families have the environments, the resources, the services, and supports we need not only to be healthy, but to thrive. And I know that sounds kind of lofty sometimes, but I think over the past 25 years, our work, the work of SCAGO and others, proves that if you believe that change is possible, it is. You just have to work it. A few examples from us. Our work has led to the establishment of Taibu Community Health Center, which folks may know about a community health center based in Scarborough, Ontario, that's really designed to serve Black families across the Greater Toronto area. More recently, our work has been focused on mental health, and we've been able to actually work with community and government to scale up a mental health service. It's called Advocacy currently, from one program site in Toronto across the province, so 9 at the end of this year, moving from $200,000, which it was funded at for 20 years, so that's a whole nother story, but to now $6 million. We've been able to work with, thank you. We've been able to work with folks on other elements here. So you'll see Angela there on the side. Angela will wave from Roots Community Services on driving forward the Peel Black Health and Social Services Hub. It's the first hub of its kind, in my opinion, that is bringing together primary care, social service, mental health, and addiction supports all in one home, one place, to support the kind of challenges that we face, whether it be sickle cell disease or other pieces. That's $25 million over 3 years, and Roots is one of the main leaders behind that effort. I'll move beyond some of the highlights there, and I think I'll say, you'll hear a little bit more over the next couple of days about SCAGO and some of the work that it's doing. So whether it's the quality standard that Paulysha is speaking to, or some of the psychosocial supports that are in many of the communities that Black communities are going for supports, working with community health centers, I really want to emphasize this piece around fundamentally believing that change can happen, and I'm saying our work is evidence that it is possible. I have 2 more points. The first is, for many folks, systems change is kind of this amorphous thing. We talk about it, but we don't really know what it means. The way that we think about it at the Black Health Alliance is really focused on a couple of things. Families and people, programs, systems, education system, health system, et cetera, and the policies that undergird all of that. So when we're thinking about change, we're thinking about how are we looking at the system? How are we looking at, for whatever issues, what can we support families to do for themselves? What can we support in terms of building innovative or filling the gap with programs that help families do what they need to do? Systems are interesting because we kind of think of the system as a thing, but the more I do this work, I realize that's not really true. It's a bunch of people sometimes, a building, et cetera, so it's hard to figure it out. But once you do, the way that we think about it is if we can make an intervention in that system, whether it's behavior or whether it's getting them to see things something differently, or getting the union, or you'll be surprised actually. It's a side point, surprised. Sometimes we think we understand the issue, but really once you dig deep, you realize that actually no, streaming isn't driven by the school board. It might be driven by the union. That's a side point, but the point is really getting deep to understand what is driving it and making an intervention into the system that's going to produce a beneficial result. And then the policies that support that. The work that our organization does, and I dare say SCAGO does, is try and coordinate that. How are we getting people to support themselves? How are we getting the programs in place? How are we getting the policies in place? And how are we intervening in the system to get that all to work together, again, to produce that better result? A couple of lessons, so this is my last section, that I've learned through this work is that, one, people know what they need. It might not come straight in a policy paper or an academic paper. It might come through tears or crying or cussing, but they know what they need, and if we listen closely, we can identify what we can do to support a community. So I think I'm encouraging us all to listen and listen more deeply. The second is that there's a power in the story behind the curve. So I don't know if folks have heard this idea of the story behind the curve, but you'll have to see a graph and it goes up and then down, et cetera. So that's the curve, like a bell curve. And normally we in advocacy and systems change, you'll see people either kind of go heavy on the data and the graphs or heavy on the story. But where we found the most success is where you can help people understand what's happening and follow that with a story that's helping to folks to understand what the story behind the curve is. That's where we've seen the most success. The third is no one's in charge and nobody's coming to save us. So I know that sounds terrible, because there are many good folks in the system doing amazing pieces of work to drive this work forward. But the more and more I do the work, I think I grew up thinking that somebody was looking at the data and looking at the system and saying, okay, this group or this issue needs support. How do we mobilize around this? And the more I do the work, I realize that that's not the case. And so organizations like the Black Health Alliance, organizations like SCAGO, actually in that gap become much, much more important to be the ones that are taking responsibility to, again, drive that systems change, that families, program, systems, policy approach that I was talking about a little earlier. A relentless focus on delivering results. So you might see there's a lot of passion here, and some of the things sound negative, but I don't mean it. Sometimes we have to be honest and look at the issue. If I take it away from health proper and I say the issue of poverty, for example, 1 minute? Oh, wow. All right. If we take it away from health and we talk about poverty, for example, and we say, how many people does poverty affect, or Black folks does poverty affect in our city or in our province? I think the work that folks are doing with the 10s and 20s is amazing, but if we're not developing a solution that's sizable to that number, let's say it's 50,000, 70, 80%, we're not having a real conversation about how we transform that issue. And so I think it's important that we emphasize this relentless focus on delivering results. Not doing that, for me, isn't good enough, and I think it's important that we do this. So last bit here is, you can't do this without money. For the majority of Black Health Alliance's existence, it was volunteer run. So folks leaving their job and then working on these issues off the side of their desk. And where we've seen the most transformation is where we've been able to hire talented staff, researchers, health promoters, folks who engage community, folks who can work with communities and policymakers to design strategy and to implement those results. And so I think maybe this is a shameless plug for SCAGO. Go on the website, click that donate button with whatever folks can deliver, because again, you cannot do this work without the support from the community and the financial resources to do so. And lastly, I'll say, I think at the Black Health Alliance, again, our track record, I think, shows that this work and change is possible, and I think we're so grateful to be a partner of SCAGO and so grateful to continue to partner, and proud to be here today, and thank you for the invite. So I'll leave it there.
Last but not least, our final speaker for this session is making his way to the podium already. I'd like to welcome Dr. Deji Oyerinde. Dr. Oyerinde is a community psychiatrist and clinical director in Kingston, Ontario. He's associate professor at Queen's with interests in global health, social determinants of health, and health equity. He specializes in psychiatry and addictions with training in London, holds various degrees, including an executive MBA. Deji is involved in consultation, training, advocacy, and advisory roles globally, focusing on cannabis and mental health, public health policy, and health ethics. Please join me in welcoming Dr. Oyerinde.
Thank you so much, Jennifer. It's always humbling to see a wounded healer. I thank my colleagues who've spoken before me, and in presenting today, I'd also like to honor the memory of fallen colleagues, friends, families, loved ones who inspire the work we do. Many of us find a reason for advocacy deep within us. And if we are opportune, we use that to continue to build on work. Early career, when I had a head full of hair, a full afro, young doctor without a pot belly, fit, and so on, I was a house officer in obstetrics. My very first on-call, a woman with sickle cell went into DIC crisis. My very first on-call was the first mortality as a doctor. It was related to sickle cell. This was an amazing lawyer. I'd met her prior to that. The baby survived, mom didn't, and we all wept. And I thought, what the heck is it about being a physician? It's not the letters behind your name. There's more to it. And every single story each of you have in this room, whether you've shared them or not, or you hold them in your hearts, plays a role in this presentation, and a lot more work we can do. Although I've referred to it here in the title as I was officially given as physicians, I'd like to say health professionals, and even broaden it to all of us in our different communities. Every single one of us here has a role in advocacy. Whoa. Great. So Ms. Lanre gave a definition of advocacy earlier, so rather than just parrot and repeat it, I'll touch on some of the points, but really it's actions, activities undertaken alone or in partnership to influence keywords, policies, practices, attitudes to improve health outcomes, to champion health-related causes and working towards systemic changes that promote well-being of populations. So every single one of us can. It could be an attitude. And how can we in different ways? I'll try and point this in again. If it doesn't, I'll just, oh, there we go. Now, in the work and the opportunities we have available to us, I've put some words there we can think of. So your advocacy can be always on. And always on is switched on all the time. 2018, I was here, quite fresh. It was my first SCAGO conference, and I got put on a wristband. I couldn't take it off. This wristband, I promise you I do wash. This wristband has not left my wrist since 2018. It has led to perhaps up to 300 conversations. It's on my right hand. I write with my right hand. Every time I'm writing in clinic or in anywhere, I know it catches people's eyes. Sometimes people ask. It's an opportunity to talk about sickle cell. I'm right-handed with my handshakes. Every handshake, it's occurred. I've had conversations in police stations, with immigration, on buses, on trains, in courts, with strangers at parties. And that's an example of being always switched on with your advocacy. Or it could be talking about in certain situations. Or the advocacy could be like a pulse. If you think of it like a pulse, we all have a pulse here, otherwise we wouldn't be here, at intervals. Now, it could be that every Sunday at church, or there's a sickle cell club or group that meets at a particular interval. And that's a way where you can actually also have fixed interval awareness and advocacy. Or you can have big tents. And your big tents are events like today, Sickle Cell Awareness Day. We must never waste, if CN Tower goes red, grab it, make the stories, make people curious. If the City Hall's red, grab it. If Niagara Falls go in red, it's not blood, grab it. And these are huge opportunities to have conversations. We should never, ever waste our tent events. They really are huge opportunities. We'll wait to see what spins out of today's gathering as well. Imaginary click. So thinking of advocacy, most of us here have a cell phone. Most of us are familiar with these symbols. And in advocacy, if we start on the furthest left, the black one with a plus minus sign, one of the first bits is just to even evaluate where you plug your energy source. If you put it the wrong way around, it could be harmful. So how do you plug your energy source? And if you found it low and there's a need for advocacy and to support a cause and understanding, then you can plug in your energy as health professionals. And you keep plugging it in and supporting in any way you can based on what you've heard. A reminder to all of us in healthcare here, we are deeply privileged to support people through some of the most distressing periods of their life, at the times when they're most vulnerable. That privilege and power that you have in that therapeutic relationship is way more than a paycheck. Your privilege is way more than publications. Privilege empowers you to do advocacy and policy work. So privilege in consults as health professionals are way more than paychecks, publications, but are a key to doing advocacy work. And when you've plugged with the advocacy and you support the group, recognize your limitations as well. Your phone charger does not own your phone. It doesn't own your apps. It's supporting the phone, but it's not. And for health professionals and so on, it's for us to support with humility. Maintain the dignity of the person who's receiving this support and care. You are not the phone. You're the energy source through your advocacy. And know your place. Next slide, please. So opportunities may occur through media coverage, for instance, media activities, news, opinion editorials, debates, podcasts, conversations. And these can be used to draw attention to sickle cell and particular aspects of sickle cell. They can influence dialogues and influence agendas as well. We can use this to also highlight concerns. There's so much misinformation, disinformation out there. The difference between the mis and the dis is misinformation could be errors in understanding and so on. Disinformation is deliberate, wrong information. And there are people who have malevolent intent that involved in disinformation. As health professionals, we're well positioned to question harmful practices and interventions and correct them with the voice or the platforms we may have, and also to call out harmful commercial interests. As health professionals, we're in a good position to critique policies, point out the policy gaps. Well-meant policies and interventions may still be harmful or cause inequity. An example here. Many people with sickle cell probably end up using or have one of these used on them. Many people with sickle cell may have darker skin. For over 30 years, it's been known that these pulse oximeters are not reliable on black skin. They're not, because they use passive infrared light. And this has been known for over 30 years. Over the last 2 years, the FDA has called a review of pulse oximeters because original calibration was not on dark skin. In the UK, the NHS has called out safety issues to do with a pulse oximeter. Publications have come out on it. Advocacy has come up in The Economist and so on. And are we able to have these conversations and mobilize bodies like this, others with hemoglobinopathies or heart disease, long COVID, etc., pulmonary disease, to challenge Health Canada for policy change as is going on in the US, Australia, the UK, etc. This is an opportunity. I feel incredibly blessed to have long COVID because I've been able to then talk about my own distress with these experiences. I feel very blessed now to have birdseed and be on all sorts of medication and be under cardiac care and respiratory care, because now I can authentically speak as a person with lived experience. And I have realized that all my years of medical education were grossly inadequate for understanding palpitations and arrhythmias. They were grossly inadequate for understanding the weakness and fatigue, grossly inadequate for understanding breathing issues. And when people say they can't breathe, it's because they can't breathe. They're not comfortable. So are we able to harness that? Next slide, please. So Again, health professionals have opportunities to participate in lobbying for specific policy changes, roundtables, fora like this. This is an amazing conference that's going to spring so many opportunities, reviews, guidelines. We've heard about quality standards as well. And can we, as people with lived experience of sickle cell or families, can we challenge our doctors or health providers? So say, you know, nurse, doctor, or whoever else the provider is, what are you doing to advocate for people like me? Challenge them. Legal channels. The lawyer may think, oh, well, I don't really have a place in this. No, you can challenge and support groups. You can do pro bono work with the resource you have. Your law firm may decide that, okay, we will support one sickle cell case per year, or we're going to support sickle cell charities as this law firm, as a cause we believe in. Engaging, empowering. I won't spend time on this because it's, again, we've heard about the communities. Helping, support, like charging the phone. You do not own the phone. Don't rip people of their dignity because you're helping them. So as health professionals, we have a role and responsibility to participate, to avoid sensationalizing and oversimplifying, exaggerating, or misrepresenting evidence. We don't want to contribute to fake news. Inappropriate advocacy can be harmful, misleading, or cause mistrust. Awareness of our professional biases and knowledge uncertainty. If you don't know, no shame, you just don't know. And there were, okay, so there are opportunities, we can build coalitions. Today's a great start. We can all do it together. Every single person here can make their health professional a better committed person in this space. Your wristband, your pulse oximeter, your bird seed or medication. And if you don't get it, and as I walk to the seats there with the look I'm getting from Jennifer, an opportunity also, a lot of people with sickle cell experience mental health challenges. As we explore the concept of a sickle cell syndrome, recognizing mental health as well, here's an opportunity to challenge as well. And for the people of color here, if you use the washroom and the tap doesn't come on, it's the passive infrared light, similar to this. And you wonder why some white dude walks up right there, it goes and works. That's what's going on. You weren't paranoid. Thank you.
Thank you all. So we had a fantastic lineup of speakers, and Paul, it looks like you wanted to. Oh, no, I'm okay. Yeah, thank you, though. All right. We are running a little over time, but I want to make sure that there's an opportunity for a couple of questions. So maybe we'll limit it to 2 questions. Delaney has the mic. Does anyone have a question that they want to get us started off with? And if not, I might get to ask a question.
Perfect.
All right. So in each of your talks, you mentioned about some of the challenges and some of the obstacles that you've overcome. And Lanre, in particular, in yours, you talked about getting past that frustration, getting past that no. And I wonder if each of you could maybe give an example of a time in your work that you've had to get past a no, how you've turned that no into a yes for the advocacy work that you've done.
Thank you, Jennifer. So in advocacy, there's always a lot of no's. In the beginning, a no might not just be saying no, it might be ignoring you, it might be not responding, it might be sympathetic, but not doing what you want. And over the years, I'll tell you, with SCAGO, there have been so many years that we were trying to engage with the Ministry of Health. We met with different ministers, so many of them. Ministers of Health, they gave us the meetings, they listened, they sympathetic, but you don't see anything happen. So that's a no, because you're not saying what you want, you're not getting the result, but we did not give up. We keep pursuing, we keep asking for the next meeting, we keep bringing more facts and so on and so forth. And eventually, they started to listen. We talk about health equity. We talk about inequities faced by the Black people who are predominantly affected by sickle cell. We talk about the challenges that this community has and so on. And we make sure that they do understand. And I think after some time, especially I think during the COVID-19 pandemic, that really helped. A lot of them to start to see reasons, with those death of Floyd and all of those, to see actually the inequities faced by this community, and then we started to get their attention. And so, like I said, persistency, not giving up, keep it up, and that would help you. Thank you.
So I am here on behalf of Ontario Health, so I'm in a slightly different place than folks here on my panel. So when thinking about what our example of a no is, that may mean that there are certain priorities or approvals that lead to a no internally within a government agency. But I do recognize that everyone has their own different place in the system to advance health outcomes and reduce disparities. So in our role, we review the evidence and put forward evidence-based solutions. But again, I do want to emphasize again how we all play a different role in terms of advancing health outcomes. So raising that to governments, working together in partnership like we have in the past with SCAGO to advance those health outcomes, and then continuing to have information sharing sessions like this, and continuing to advocate externally. Those are some of the methods where we can address a no and turn it into a yes.
Thanks, Paulysha. So, nobody's actually ever told me no. I think similar to what Lanre is saying. Using the example of Advocacy, it took 5 years to get from like my initial engagement in the advocacy to get to like the first initial investment. And the way that I think about it now, it's that folks aren't necessarily giving you the no. And like Paulysha is saying, everybody has their place, and it's actually our job to get all the ducks lined up, if that makes sense, understand what everybody's agenda is. Ministers have a different agenda than folks who are working in the bureaucracy of government. Community has a different agenda sometimes from those folks in government, and as the chain goes on. So if you understand all of those folks and kind of what their job, pay, and gain is, like how to get them aligned, then you get to delivery. But realizing it does take 5 years to deliver that change. And so, with that 5 years in mind for the work that we do, we realize that it's not a 1 or 2 year thing, it's a generational kind of shift that I think we're gonna have to try and make. So that's the investment that that we're making, and kind of how I approach the concept of no, get people aligned.
Thank you. I've probably been luckier than you. I've had quite a number of no's, but for some of the no's, is the person saying no, do they even have the authority in the first place? And sometimes the person putting the blocks in the way doesn't have the power. And are we using the right levers of policy for these no's? Or is it a great request at the wrong time? Political campaign periods are excellent for turning no's into yes. Get the conversations into policy conversations. When people are looking for votes, get the agendas on. If someone's not attending your summit or your meeting and so on, ask them to find a representative there, and you're still able to share the brief. Mix it up a bit. There might be someone else that's more charming or able. But so the no doesn't mean a no all the time, and it's how we creatively engage with the individuals, many times recognizing that the person who says no doesn't even have the power, and you look for the person who's got the power. Thank you.
All right. So that's a great way to end off this session. Thank you again to all of our speakers. You've left us with lots of food for thought and inspiration, and a great way to continue on this year's summit. All right, so we have a brief break. There are some refreshments just outside, so please take a few minutes, get some refreshments, and then you'll follow your program to your next sessions.
Beautifully said. We'll take a 10-minute break, folks, if that's okay, and then we'll kick off our concurrent sessions at about 11:10. Thank you so much.